number of COVID-19 infections in South Africa continues to increase rapidly, with almost 200,000 positive cases and more than 3,000 deaths. There have been concerns about the capacity of public and private hospitals to deal with COVID-19 patients. So is our healthcare system still coping? To help us unpack that, we speak now to critical care physician and Emeritus Professor Guy Richards. Thank you very much for joining us. So you believe it's not just an issue of having enough beds, but in having enough staff as well as ventilators. From the work that you do on the ground, what is the situation?
So essentially having a bed means having sufficient oxygen, perhaps ventilators, but having sufficient oxygen and having sufficient staff. So if you've got oxygen, staff and a physical bed, then you can say you actually have a bed. If you provide a facility that has 2,000 beds but hasn't got staff or oxygen, well then obviously those beds are in fact non-functional and are not of benefit to the system at all.
So somebody comes into the hospital displaying some of the symptoms, tightness of the chest, unable to breathe. What happens?
So as you know, there are three phases really to the illness. The first one is the upper respiratory tract infection. In fact, some patients are entirely asymptomatic. But the upper respiratory tract infection is the initial phase. Thereafter, you get the pneumonic phase, which is a phase in which you get a form of pneumonia. It's a viral pneumonia that you get. And then a third phase where you actually develop the so-called hyperinflammatory phase with other organ dysfunction. Now, when a patient comes into hospital and they are known to be positive or they are suspected of being positive, then they are assessed in terms of their clinical features. Do they have evidence of a low oxygen in the blood? That is the primary reason that one would admit patients to the hospital if the oxygen in the bloodstream is low, which implies that the lungs are not able to transfer oxygen from the lungs to the blood appropriately. Now, those are the patients that are at risk. So the initial thing you do is that you would administer oxygen. And there are a number of different ways that you could administer oxygen. First of all, you could use just a nasal cannula, 2 little cannulas you place in the nose and you administer oxygen in that means. Thereafter, if that is insufficient, one could use so-called high-flow nasal oxygen, which is a specific device that is able to deliver oxygen up to 60 liters per minute. But that, of course, depends upon the availability of an oxygen plant that can provide that amount of oxygen as well. Or you could then go on to so-called non-invasive ventilation, where you place a mask over the face and then you deliver oxygen by a positive pressure so that the patient is still breathing on their own, but they're breathing this oxygen through a positive pressure mask. And then the fourth phase, if the patient still deteriorates despite the medication administered, you could then go on to mechanical ventilation, where you place a tube in the throat, and then the machine will then take over the respiration and the breathing for the patient.
We understand that the ventilator program is expected to deliver some 20,000 ventilators from the country. So in terms of the staff that we were talking about a little bit earlier on, who will then administer this process, what does it take in terms of training them?
Well, if we're talking about the earlier categories in terms of the nasal cannula, high flow, or the CPAP, that does not require a significant amount of training, and patients, doctors and nurses can be quickly trained to utilize those devices effectively. When we're talking about more complicated mechanical ventilation, that is a much more difficult phenomenon, and in that setting you need more training as an intensivist or an anesthetist in order to utilize the machines appropriately to deliver oxygen, not to harm the lung, because you can have a factor called ventilator-induced lung injury, whereby if these machines are used inappropriately and delivered too high a pressure, you can actually damage the lungs.
Professor Richards, allow me to use this opportunity to get some clarity on this, and that's if you know more about the situation. A lot of information doing the rounds in terms of hospitals running out of capacity, especially private hospitals in the country, seeing a large number of patients streaming in. Is there anything that you are aware of in terms of this?
Well, I think all the hospitals are being overrun somewhat at the moment. I know that most of the private hospitals in Johannesburg are inundated with patients, as are the public hospitals, and in particular the Charlotte Macheke as well as Chris Hani Baragwanath. So there are enormous numbers of patients that are currently attending or coming into the hospitals, placing a huge burden on the facilities that one has. In addition to that, and we heard this on the news just shortly, is the large number of healthcare workers that are currently being infected. And each day we have more of our healthcare workers who go down with COVID-19. So fortunately, touch wood, we haven't lost any of our healthcare workers here, but a number of them have become critically ill. And even if you don't become critically ill, you have to stay off work for at least 14 days. And that just exacerbates the whole problem.
Are you aware of patients being turned away from hospitals because there's simply no capacity?
On occasion, some hospitals are put on so-called divert, and that means that when they are on divert for a short period of time until beds are able to be made available, then patients would be sent to other hospitals. But that is given in an instruction given to the ambulances, who would then know where to take the patients thereafter if a hospital is on divert.
Thank you very much for your time this afternoon. Critical care physician and Emeritus Professor Guy Richard.